Thank you and good afternoon. So as we heard earlier, the first shoulder arthroplasty was actually a reverse arthroplasty by the great French surgeon Jules-Émile Payon for tuberculosis. And in terms of modern shoulder arthroplasty, Charles Neer in 1951 released a one-size-fits-all concept where the onus was on the surgeon to make the implant fit to a variety of variations in patient anatomy. We are currently in the fifth generation. We heard nicely earlier about stemless arthroplasty, and I've been involved with a couple FDA clinical trials in the United States. And we are currently in process of the first clinical trial of the stemless reverse in the United States, which is depicted here. So where does all this technology, where is it taking us? Well, we're living in an age of precision medicine, a medical model that proposes the customization of healthcare with medical decisions, treatments, practices, and products and implants being tailored to the individual patient. It's data-driven, individualized, evidence-based medicine, and in the context of this, we are developing more and more patient-specific intraoperative guidance and implants. Currently, we have 4 commercially available PSI systems in the United States, which are listed here. But remarkably, what we're lacking in the peer-reviewed literature is clinical studies to evaluate the impact of this technology. Is it really making us better? And is this going to translate into better outcomes and longevity of the prostheses? I think we can all agree the benefits of this new technology is certainly we're better in terms of surgical planning. I think we're thinking about deformity and complexities on a whole different level than we used to, even with two-dimensional CT imaging. It enables shared decision-making with our patients, certainly good for marketing, and being someone who practices in the Silicon Valley, surrounded by high levels of people, engineers, CEOs of various companies, and so patients want to be more involved in what you're planning to do before you get to the operating room, and at least they appreciate that you're thinking about it. Training residents and fellows and our future surgeons, I think that these software tools enable better enhancement in education and discussion. And here's a fellow of mine who is actually virtually performing an operation before we even get to the operating room, and we're studying whether or not this enhances learning. This is the Precision OS product, which is in development. Intraoperative precision, as we see here, we have tools now that enable the surgeon to translate the surgical plan to the operating room, and I'll get into more detail about this as we move forward. But again, the question remains, is this going to translate to improved outcomes? So what does all this new software not assist us with? Well, most importantly, it comes down to indications, patient selection, surgical technique. I think that it's all about the exposures, so I don't care what software or guides you have available to you. If you're an inexperienced surgeon and unable to expose a glenoid adequately, it doesn't matter. And so the releases will continue to be important, proper glenoid exposure, implant placement, and as was touched upon earlier, the soft tissue balancing is excluded from many of these products currently. So it comes down to surgeon experience, and I think experience does matter here. We all know the surgical indications for reverse shoulder arthroplasty. I think a growing area in my practice is using the reverse more and more in select patients with an intact rotator cuff perhaps and severe glenoid deformities or a rotator cuff at risk. And so we all have elderly patients with high-grade partial tears, and so it would be a disservice to go with an anatomic and later convert to a reverse. And so here we see some examples of some of the more complex deformities that we can face in our practice. But before we get to the CT scans and the software, standard preoperative planning always begins with X-rays, and so we're looking for static instability on the AP views. We're looking for proximal migration, the acromion-humeral distance, and we're using the axillary lateral to better define the presence or absence of arthritis, but I think it's very restrictive and inaccurate if we're using the axillary lateral to define glenoid morphology or retroversion. And remarkably, many of the studies looking at clinical outcomes following arthroplasty are relying on plain X-rays, and I think it's inaccurate. The CT scan is routine in all cases for me. It allows for precise calculation of glenoid morphology, version, fatty infiltration of the cuff. And it's a requirement for all of the various systems of software that are available for us today for surgical planning purposes. And so here we see the oblique sagittal sequence, which we know well, the Goutalier classification, and here is Gilles Walsh's well-known, well-described classification system. So for me, one of the questions that I'm often asked, do you use these software tools for every case? And I will say, not for every case, but certainly for the more complex cases, I will utilize the software and the guides to have an added layer of security and thinking at the time that we get to the operating room. Here we see an example of a significant medialization, bone loss, and so forth. So this is going back to earlier in my career, 2005. We had an elderly female who had had 2 failed rotator cuff repairs, metallic anchors, rotator cuff tear arthropathy, and recurrent massive tear. And so using the oblique and then finally 14 years follow-up, we had a good clinical outcome here with a delta prosthesis. Joe Iannotti, who was really credited with driving a lot of this technology in terms of preoperative planning and PSI technology, is quoted here saying that 3-dimensional imaging improves significantly the placement of the glenoid components. So when you compare here standard instrumentation to PSI, there is much clear levels of precision in terms of entry point and restoration of version and inclination in the final implant that is placed. This is Frank Golke's study looking at his experience, the influence of 3-dimensional planning on decision-making in total shoulder arthroplasty. His findings showed that 2-dimensional CT scans much less accurate compared with 3-dimensional measurements in software. So what did we do in the old days? And many of us have been here. This is a 58-year-old male, primary OA, and we can see here some glenoid retroversion, posterior subluxation, and so this was quite innovative. This is Christian Gerber's work, where we would use CT scans to, in a cannulated manner, do controlled reaming to restore glenoid version during the time of the anatomic prosthesis placement, as we see here. And so controlled eccentric reaming was highly innovative at that time and has evolved further to the present day. But what would we do today in 2020? Well, I think that pre-op planning software is a useful tool. Intraoperative guides can be utilized. We know well today that preservation of glenoid bone is of paramount importance. We want to avoid over-aggressive reaming, which can lead to early implant loosening. I have adopted the use of augmented glenoid components in my practice more and more, moving more and more away from structural grafts such as humeral head autograft or tricortical iliac crest graft. And I will use this software routinely for the more complex deformities. On the humeral side, I'm evolving more and more to short stem or stemless implants, as we see here. So as Walsh and others have shown us, the goal is to preserve glenoid bone as much as possible. And although radiographic loosening doesn't always correlate with clinical loosening, I think it's important for us to preserve glenoid bone as much as possible. Furthermore, overaggressive reaming can alter the soft tissue balancing of the native center of rotation and the glenohumeral joint. So with the use of either grafting or with augments, we are better able to maintain satisfactory tension on the rotator cuff and other soft tissues. And so here's a 51-year-old male with a type C glenoid retroversion of 30 degrees and posterior subluxation of nearly 90 degrees. Intact rotator cuff. So what do we do here using the software? Well, we start with trying to dial in how much correction we are aiming to achieve. And so here, if we go to 5 degrees of retroversion and we aim for seating of the prosthesis of 92%, we would need to, at least on the basis of this plan, ream 3.5 millimeters. And so that is too much bone elimination, in my opinion. So the plan B is an augmented glenoid, as we see here, which allows satisfactory seating. And so this is the final plan. Well, what about a reverse with an augment? Perhaps if the patient was older, we would go with that route. But I elected to go with an anatomic stemless with an augmented glenoid. We have a nice 3D printed model, which is available on request at the time of surgery, intraoperative guidance, and we can execute the plan, as we see here. So in the interest of time, we're going to skip forward a little bit and get to the end. Different patient here, 70-year-old female, superior bone loss, cuff tear arthropathy, and proximal migration. And we're going through the surgical plan once again. This patient had glenoid retroversion of 20 degrees with inclination of 34 degrees. And so what we elected to do here is utilize a metal augment superiorly to accommodate the bone loss, reverse prosthesis, and execution. I think the key steps for patient-specific guides is to expose the glenoid, to maintain osteophytes, and to avoid posterior retractors pushing you forward, as this can alter your pin placement and translate the surgical plan to the OR. One other system that's out there that I have experience with comes from Arthrex. This is the VIP system. It was designed by Joe Ionati and sold to Arthrex. This is an 81-year-old female, excessive retroversion, 36.6 degrees. And so this is a context, this was before I had metal augments available to me, and so I elected to go with a structural humeral head autograft, as we see here. And this is a reusable guide, which you can place into patients. This is the Arthrex reverse system, and she did well. This is briefly a study comparing conventional and computer-assisted base plate positioning and reverse arthroplasty. 5 surgeons, 30 specimens, and the finding was that CT imaging improved precision and accuracy significantly. This is Dr. Favard's early experience using shoulder-specific guides, and he found in retrospect that it was difficult to control rotation and reaming with patient-specific guides. Finally, this is Joe Ionati and Eric Ricchetti's prospective study comparing 3 various systems, and they found that they translated to better precision and accuracy in surgery. I think opportunities for improvement are improving on rotational control and depth of reaming, and as we said earlier, glenoid exposure continues to be the main challenge. So in conclusion, preoperative planning software and PSI guides enhance our ability to translate our virtual plan into reality with enhanced precision. We have guides, we have 3D printed models. I think ultimately we're going to move to patient-specific implants moving forward, especially useful in complex deformities of the glenoid, the B2s, the B3s, the C glenoids, the D glenoids. And I think ultimately what we need is more clinical data. And so this will come with time, but I'm optimistic that this technology will actually enhance our outcomes and our performance and longevity of implants in the years to come. Thank you.